I'm going to say a few words first, Dr. Sorrell. So it's really wonderful being here these last couple of years. I love coming here, by the way. It's kind of like when I get a consult, by the way, it's always a highlight of my day. So just keep it up. All right. So thank you for your support. And there's increasingly we're seeing psychiatrists are getting extra training in reproductive health and women's health. I'm not one of those. My experience and my interest in mental health grew out of three seminal experiences. One, my mother had postpartum depression after being hospitalized after my birth. Second, I've had three ex-wives. Third, I've successfully raised 5 girls, and by success I mean they were survived. And I will tell you that my experience in this field, mostly in those 3 roles, was more provocative than protective. So psychiatry, when I entered it in the 80s, was supposed to be the dedicated brain, and I anticipated being more of an internist. I'd have more tests, more studies, more science. It's very disappointing, the state of psychiatry, and we're still doing things that which we have very little support, and particularly in the realm of treating women reproductive status and pregnancy. And so everything we say has caveats, and you guys know that, because in fact, all of you have been treating more women who are pregnant with mental health issues and depression than I ever will see. And we also have to have a sense of humility about that, because for every Birchow or Coke or Semmelweis or Snow that's made rapid and made incredible impacts, there's a guy named Coleman who came up with a novel treatment for hyperemesis of pregnancy in 1895. By the pregnancy was the vomiting was so bad that they decided to terminate the pregnancy, attempted to dilate the cervix, and immediately her nausea stopped. So that became the treatment of choice, stimulating and trying the cervix and subsequently rectally for 40 years. And so, based on one example, when that's something that we all in medicine have to be on guard about. And so as we have these discussions, sometimes we're all influenced deeply by that. I want to keep that in mind. We're going to talk about one particular case, but if you've ever tried to get a psychiatrist on the phone, you'll know that it's almost impossible. So this is your chance. If you have other questions or concerns or interests that you'd like us to address, please interrupt, ask questions, make corrections, may have observations. We do not, I would be very disappointed if we spent all our time talking and you guys spent all your time listening. So that's the frame that I want to give for where we are today. So with that, I want to turn this over to Ben and to Kim. Kim actually is with us only very part-time now, but we're going to lure her back. All right. So this next year, full time. We also, I want to, Leanne Mercer's the nurse that works in that clinic as well. So who dodged to be a part of the presentation. So that's the team we have here. And although I'm not physically here much other than the consults, I am intimately involved in helping and with Ben kind of managing these cases. So any questions or concerns you guys have about care we're given or things you need, please just give me a call. All right. Appreciate it. So with that, Ben, Jim, rolling.
Thank you, Dr. Sorrell. All right. Hello, everyone. I'm Ben Franzen. I'm a psychiatric nurse practitioner. I have been covering the clinic for mental health here at Women's. Excuse me. The computer seems to not be working. For a little bit over a year now. Actually, coming up just on a year. I also help Dr. Sorrell do inpatient consults as well. So you've probably seen me around helping with that. And starting out, just a little bit of background about me. I was in the emergency department for 12 years before I went into psychiatry. And when I told my friends in the ER I was going into mental health, one of my charge nurses, very eloquently, as ER nurses are known for it, told me I needed to get my head examined myself. And almost every other specialty in medicine, when you talk to them about mental health, it's either I love it or I hate it. And as I talked with people about why, and this is something Dr. Sorrell kind of already touched on, mental health is a sea of gray. And we as clinicians and providers don't really like gray, right? We like black, we like white. We accept that there's sometimes a little gray in the middle, but we like to have that small and minimal space. That's not the case with psychiatry. We don't have very good data for a lot of things, We don't have, this is the absolute best treatment. We have, well, these are really good options. These are kind of good options. And these are options you probably really shouldn't consider for most reasons. Okay. And everyone just starts to feel uncomfortable with that because it goes against what we want. We want data. We want things that say, yeah, this is good treatment. Yeah, this is good diagnosis. And that just doesn't happen, especially in mental health, you know? So with that being said, moving into what we're trying to get here today, specifically, I get a lot of referrals regarding peripartum, postpartum depression, anxiety. Okay, and a lot of patients come in, they're kind of asking about what's the best med. You know, everyone wants the best medication. All of my patients who I see for peripartum and postpartum are focused on what's going to be the best thing for me, not causing harm to the baby. And again, we don't have great data, okay? But the thing is, we dig into the research is we've found that what's worse for the patient than the perfect med is not treating at all, right? Even if you're using the quote unquote wrong med, outcomes tend to be better in most cases than if you don't treat at all, okay? So for a lot of my patients, I just have to tell them, I can't give you the perfect med. I can't guarantee that this med's going to be 100% safe for baby. I can't tell you that there's no chance this will affect baby. I have good safety data on these medications that I think would help you, but I can tell you that what will almost certainly be worse for your baby is if we don't treat you at all. Okay? And so oftentimes then the question becomes about, do we switch medications? I know certain people really like a med. They find a drug that works great for anxiety, depression, and they're like, yeah, this is great. I'm going to use this med. I'm going to give it to every patient I see. The issue with that is sometimes the patient did well on a med previously that maybe isn't that clinician's preferred med. But if the patient had a really good positive experience with that med before, chances are they're going to respond really well to it again. So another thing I want you guys to consider is keep using what worked before if possible. Okay. And this even actually came, and I'm going to pull this up here towards the end of the presentation, from some data and handouts that I actually pulled from the American College of Obstetricians and Gynecologists. We'll kind of go through that, talking about some treatment pathways for postpartum anxiety and depression. Okay. The other thing is, again, talking about making changes to medications, if possible. And again, the American College of Obstetricians and Gynecologists recommends this. If you're changing medications because of a concern obstetrically, please talk to the consult the prescribing provider. Okay, especially for me, I am available on Click. You can message me on Cerner. You know, if you have concerns about something that's being prescribed or questions about anything, reach out. Let's have a conversation. Let's see if we can arrive at a better solution. All right, I'm happy to make changes to plans based off concerns that you have and try to do the best that we can. And I think that's true for almost everyone in our clinic. So recent developments. This is the probably biggest news, and I'm sure you'll start hearing about if you haven't already. In August of this year, the FDA approved zuranolone for treatment of postpartum depression. Okay, zuranolone is the only oral medication that is indicated by the FDA for treatment of postpartum depression. Prior to that, the only other option was brexanolone, which is poor oral bioavailability and has to be done via infusion. Zuranolone can be taken orally, and it has a very fast onset of action. Typically, we're seeing turnaround in about 3 days. Your typical SSRIs, SNRIs, you're looking at 4 to 6 weeks before you really can say you're having effect. So it's got some very positive things. However, there's some drawbacks. Specifically, the studies really only fully evaluated patients for about 45 days after onset of treatment. They're still continuing to watch it, but we just don't know the length of effect that we're really going to see out of it. With zuranolone, they're taking 1 pill a night with a high-fat meal, preferably at least 500 to 1,000 calories, because it is very sedating. People get very tired, very drowsy. Lightheadedness is also a very common side effect. So we want them taking it at night. Again, with that high-fat meal, they take 1 pill for 14 days every night, and that's the end of the treatment course. However, I don't know how much we're really going to be able to use it right now because brand new, cost and insurance coverage is going to be an issue. But again, you are probably going to start hearing about this from patients. Regarding the effect, the mechanism of action for zuranolone,
How much is it?
I
I
don't.
know. It's $15,900 for a 14-day course of treatment.
Nothing else.
Yeah, so you could write the Chris Veerbach, who's the CEO of Biogen, because he only makes about $31 million a year. So,
Yeah,
so-
yeah, he's got, so it's got a very interesting mechanism of action, and I'm interested in the future to see if this will kind of open new doors in psychiatry, but I'm not sure how much we're gonna use it for the first couple of years.
it's hard to imagine because what they usually do is they'll put it into their tiers and they'll have to fail multiple drugs, and the cost of failure over months of treatment of postpartum depression. But that's not who they studied the drug in. And so it'll probably not be effective because of, this given as a neurosteroid. And we're looking at neuroinflammatory factors. By then the damage will be done. So it's going to be a problem for us to utilize, but it does at least point to highlight some new developments in treatment of depression and anxiety, which are focused on inflammatory factors, cytokines, HPA activation through hypercortisol issues and stuff. So there's some excitement about it, but it's in terms of, I don't know if I'll ever see reading it. Just based on this. Go ahead, sir.
No worries. All right, and so last thing, Kim and I are going to talk with you about a case study patient, a patient that I have been treating in the clinic, and Kim was treating in the clinic when she was at the women's clinic here for almost a year now. So this patient is a 26-year-old female. She was GRAVITA1, Para1 without any prior mental health diagnosis or treatment. And I say that because Kim's going to talk about some past issues as we go into her section of this case study. She had a complicated delivery at 34 weeks and 4 days via C-section due to preeclampsia and a previously undiagnosed septated uterus, which preceded the onset of her symptoms. At her follow-up, her 6-week follow-up, she was noted to be extremely depressed during the visit, and she was referred to our clinic. She was started on sertraline at 50 milligrams a day, very appropriate treatment, and then she was sent over to us for further evaluation. When Kim and I both saw her, she was not doing well. She had significant worsening of symptoms. I had to titrate her sertraline up. She didn't respond as well to sertraline as I wanted to. I had to then cross-taper her from sertraline to venlafaxine. I put her on actually a good dose of benzodiazepines because of her anxiety was so awful. And I do not like to have regular benzodiazepine use in my patients, but she was so anxious, there was almost no other way to keep her out of the hospital. Multiple times, I came and talked to her about, I think you should go inpatient behavioral health. And she declined every single time. And it was kind of frustrating, admittedly, because, she was really, really struggling.
And scary at times too.
Yeah, we were very concerned for her. We did frequent follow-up visits. At one point, I was seeing her every other week, it seemed, and also stepping into some sessions with Kim on an almost weekly basis, trying to get her medications fixed and get her to have symptom remission. Today, the patient is pregnant again. She is doing far more stable. She is from a much better place mental health-wise. Still some struggles with depression and anxiety, but I'm no longer discussing hospitalization with her on a almost monthly basis. So overall, we have had a lot of success. Her case has been difficult. I talked to Dr. Sorrell about her case probably at least 4 or 5 times. Really was a struggle for me, especially being a newer clinician. But the main thing is we recognized that she had an issue when she had that postpartum visit. We started her on a drug, even if it wasn't the best drug, it still did some benefit to keep her stable while I was working to get everything else going. And we got her over to see specialty, specifically psychiatry, to try and get more done. So
What was the second drug you started?
venlafaxine, Effexor, it's a selective norepinephrine reuptake inhibitor. Kim, I'll let you discuss therapy. No problem.
Thank you for having us. I'm delighted to be here this morning. So I'm going to refer to this patient as Rachel. She is just a delightful individual. It was at the 6-week, as Ben kind of referenced or referred to it, her 6-week postpartum visit. I think that she was given some screeners for depression and anxiety, and then referred to our clinic. And what she talked about how one of the scariest things for her was in that appointment, her follow-up, excuse me, her 6-week visit, just how terrifying it was for her to admit how much she was struggling. She talked about how it felt like she was a complete failure. It felt like since she was struggling in these ways that she was potentially not a fit mother. So that was probably one of the biggest hurdles for her, was admitting I'm not doing well and I need help. So that was the first step. And it, like I said, a really big hurdle for her. When I saw her for the first time, very kind of, her baby was with her and ended up coming to most of the time, our weekly sessions, which was delightful. But she was very kind of subdued, quiet, but generally tearful throughout the majority of our sessions. The anxiety that she was experiencing at that time was just overwhelming for her, and at times felt like incapacitating for her. It was interesting. So once we were able to kind of build some trust and good rapport in our therapeutic relationship, she talked a lot about the birth experience and just how traumatic that was for her. You know, as a first-time mom, like she was, she had lots of ideas and dreams and hopes about how her delivery with her baby was going to go, and nothing went according to plan. So she felt very helpless and very out of control. Additionally, she felt a tremendous amount of guilt in saying, I don't know why I'm so affected in this way, why I feel so anxious and so depressed. There was a good outcome. My baby is healthy. I shouldn't be struggling the way that I am. There's something really wrong with me. And as we were getting into our work together, in addition to talking about the birth experience and how she felt so out of control, and working to really encourage her to allow the emotions to be present and to be able to name them, to talk about them, to articulate them, is such an important part of therapy and the therapeutic process and healing. But as we got to know each other and worked through these feelings of sadness, loss, and grief about a birth experience that she didn't get to have, a lot of issues really came to the forefront from her childhood, from her upbringing. She is the oldest of, I think, 4 children. Her mom was a younger mom at the time of her birth, and a father who was had some addiction issues and was in and out at a young age and then not present in her life at all. And Rachel really became a parentified child. So she felt very responsible from a pretty young age, responsible for her mother, who struggled with a lot of her own mental health issues. Rachel did have a very supportive set of grandparents, her mother's parents, who were really involved in her upbringing and such. But they were also enablers. So Rachel, my patient, kind of came alongside her grandparents, so to speak, in helping to really support and focus on the issues that her mother had. So caregivers, even though Rachel was a child, she was a caregiver of sorts to her mother. And caregivers are generally individuals and she was a child, but who do not focus on their own needs. They don't focus on what they are feeling. So some of these experiences as she was growing up really impacted then when she had this traumatic birth experience. Everything kind of came, you know, from the past, like to the forefront, and she felt really out of control. As a child, she was very much in control, so to speak, in terms of being a caregiver. So when the pot boiled over for her, there was so much there that we needed to address, to work through, to talk through. Lots and lots and lots of tears. We did reach out to Rachel to get some input and feedback from her about what were the things that went well. What are the things that didn't go well, like in our work in therapy together, as well as her work with Ben with medication management. She talked about how, like I said, that first step of saying, I'm not well, was terrifying for her. And this was her first experience in therapy, which was also pretty intimidating and somewhat terrifying for her. But she said just being able to come and sit down to talk with someone who was supportive, who was not judgmental, who was unbiased, you know, and didn't know her from anyone. She said slowly over time, I felt like I could open up a little bit more and share more and more. And then she shared that she really came to depend on that support that she would receive in our sessions on a weekly basis. I'm an individual in terms of my approach. It's very client-centered, so I'm not super directive in our sessions together. I feel like the client really has their own sense of, you know, what needs to be talked about in session. So I'm encouraging and might ask some questions to start the conversation. But I really feel like there's a tremendous amount of value in allowing the client or the patient to really be, to direct the course of our work together.
And piggybacking back onto that, so Kim and I worked very closely together several times where Rachel was really struggling. Kim would pull me into a session so we could discuss what we could do to keep the patient stable, Rachel stable. And Rachel talked about how she found a lot of benefit from the therapy, but the medication was kind of what kept her able to go day to day. And that brings back to a saying I came across during my clinical training, talking about anxiety and depression. One patient likened it to, I was treading water in a stormy sea. The therapy was someone teaching me how to swim, but I needed the medication because it was my life jacket. Otherwise, I would have drowned. And so typically, that's one of the things I really enjoyed while we had Kim at the women's clinic, is how closely we were able to work together to combine the medications with the therapy and keep the patient stable and functioning and able to do the things that they need to do in their life.
It was a beautiful relationship, wasn't it, Ben?
It really was. That's why we should get you back.
Yeah, I know, I have that relationship again.
That's right.
Yeah.
I have just a couple questions, just to clarify for me, because I forgot. Was there onset postpartum and or was it peri?
It was postpartum as best we can tell. There probably were some peripartum symptoms, but nothing that was clinically.
And how far is she along presently?
At this point, I
roughly?
think she's about 11 to 12 weeks.
And how's she level of depression?
I would say she is mild to moderate at this point, and she was severe for the first 6 to 8 months. And
Again, placing her at high risk for another recurrence,
Mhm.
right? Is she breastfeeding?
no, she was unable to breastfeed. Her baby has a milk soy protein intolerance, which for our perspective was good because it opened up a lot of medications that otherwise I would not have really considered.
Okay,
So
all right. Thank you, guys. You guys got a question? Yeah, go
I
ahead.
do have a question. So in our world, you know, I think we always, at least from a physician standpoint, with our busy schedules, a lot of times we kind of lump anxiety, depression together. And I think we're starting to try and tease these out as being separate conditions. in our high risk world, we see a lot of these patients that have the unplanned birth experience, right? Where they develop PTSD, and that's something that comes up in future pregnancies. Is there a treatment approach that is better if we think that a patient is more anxiety geared than they are depression geared, or if there's a PTSD component? Is there certain medications we should be thinking about? Should we be thinking predominantly about therapy first, medication second in those circumstances? Because I'll be honest with you, I kind of fall into the mold of the clinician that you said, right? That I've got my drug that I like to use, and if you are anxiety, depression, I just kind of throw this at you and see if it sticks. And
Ben does not imply a criticism of.
no, I know, but
Because I think it is really good to have a drug or two and that you're comfortable with and know the ins and outs of. I think of physicians who just sort of willy-nilly just say, oh, I think today's going to be a sertraline day, right? Is not the right approach. You want a drug that you really know like the back of your hand. And so that, and the reality is that, there's some good data on safety, primarily about fluoxetine, but the sertraline as well. And particularly because of our encouragement of everyone to breastfeed, it's the idea that we could keep them through, and that'll be to have the lowest absorption and maybe. So it's reasonable. We don't have a lot of drugs that because of our limitations of our understand of our current state of pharmacotherapy that really highlight, other than benzodiazepines, that hit anxiety separately than depression. And in fact, the use of benzodiazepines early in the treatment of depression is really underutilized because there's been shown to shorten the course and show improvements when commonly used with antidepressants. In pregnancy, I believe lorazepam to be the best by far. It's clean metabolism and less like, and also has a long enough half-life that you're not running into risk of some dependency issues. I think that the psychotherapy is key in these issues. I'm one of the things that's been kind of frustrating to me is one of the common things we're coming up for is somebody who's admitted at 28 weeks with and they're hospitalized here waiting to get them to a safe delivery point. And that they're sitting there isolated and bored, and they're not doing all the things that we recommend anxious people do, which is exercise, get good sleep, have a lot of social interactions. We're actually, I assume that if we started to do anxiety screening weekly on those patients, we'd see those scores skyrocket. So there's a little iatrogenesis going on with anxiety and by not really having really targeted focused approach, like not having an inpatient psychotherapy available for our folks that do that. So there's some issue, but psychotherapy is definitely underutilized. There's no doubt about it, right? In terms of the medications, I would say that one of the drugs that we utilize, and I still recommend in pregnancy for the very anxious patient, particularly having sleep disturbance or having trouble maintaining weight, is use mirtazapine, something you guys are mostly a little bit uncomfortable with because it's newer. But mirtazapine is a really good anxiolytic as an antidepressant. It's serotonergic, but not a re-upping inhibitor. So it's more got some agonism. So that's a great drug in the anxious patient who that's the primary presentation. So I would just encourage consideration of that. We don't really have any adverse data on it. The worst drug, the antidepressants, you guys would, Axel, right? You don't use that. But actually in probably one of the better studies, it was the most effective antidepressant in the pregnant patient. And the risk of those cardiovascular side effects is something like a 3% increase, as opposed to fluoxetine, which is 2% increase. So we've got we get these, or lithium, a perfect example for the bipolar patients. When we talk about postpartum onset syndrome, I think a really important takeaway is to realize you got a postpartum depressed patient, especially the more severe it is, you're most likely dealing with a patient who has a bipolar disorder. Even if they don't have any mania, it's really something to be considered about. So the use of mood stabilizers in patients who don't respond to antidepressant therapies, it should be given great consideration. And people run from lithium, right?
But the lithium, in fact, can be really, is the most successful drug for the management of bipolar disorder. We have a lot of data on how to manage it in pregnancy. It's just hard to do. You guys shouldn't do it because of changes in, increase in volume and GRF and all the things it takes. You have to be really cautious and careful in consideration. And then you also, the other thing is that probably I really encourage parents, mothers not to breastfeed if they're going to be on with the carb. Always avoid, don't let your reproductive age patients be on Depakote or carbamazepine. That's it's tragic because the fetal tube effects are in the first 5 weeks or so, right? So they've had the damage risk before they know they're pregnant. That's another takeaway. But yeah, I think with the anxious patients, psychotherapy is utilized. And I think the other piece is what you guys could do in your clinics regarding that. I don't know if any of you read in your training, ran across a book called The 15-Minute Hour, published in 1993. It's a applied psychotherapy for the primary care physician. And frankly, it's a great little book, and it's practical, and you can, you could call it the 5-minute hour, right? There are just things in there that just fundamentally, if you're attentive to, can provide some of the support and structure. Those things that the patient is. We reach out to the patient saying, in anticipation that, say, we're going to be talking about you, what's health, and the factors that she mentioned, are factors that you guys can all provide as well in terms of support, understanding, ear, the minute of sitting down with and making eye contact at eye level. So those are some things that I could really consider.
What was your drug you really liked? One that you said?
Anxiety, for anxiety, mirtazapine, Remeron.
Okay.
Remeron, yeah. And it also actually give consideration in the patient with nausea, vomiting in pregnancy. It shows some positive response with that as well.
Is Rachel, now that she's pregnant again, has she continued on her medications?
She actually has. So that's again where kind of one of the things I want you guys to take away from this is don't let the perfect be the enemy of the good. If the patient has had a positive response to drug, we have very few strict contraindications for most of our medications in psychiatry and pregnancy. If the patients responded well to the drug, aside from Depakote, carbamazepine, really those are the only two. If they've had good clinical response, I encourage them to continue it because rocking the boat is only likely to make their mental health worse and again, risk worse outcomes. So this is pulled from the American College of Obstetricians and Gynecologists, where I got a fair amount of my data, but they even recommend venlafaxine or Effexor as a second-line treatment for mild, moderate, or severe depression, anxiety disorder, and PTSD. And this will be, again, available as part of the materials emailed out. To go back to the comment about diagnosing depression versus anxiety, it's difficult, even we sometimes, because there's depression, there's generalized anxiety disorder, and then there's depression with anxious distress. And so I wouldn't worry about trying to tease out too much whether it is depression or anxiety, because all of these treatments here are going to be effective. So sertraline, fluoxetine, citalopram, escitalopram, all will benefit both. The main thing is, recognizing, does the patient have an issue? Are they needing the drug? And then trying to get them in. And then therapy really is underutilized, unfortunately. But again, even mild cases, we would recommend referral to therapy, but good luck finding a therapist right now. It's very hard. We struggle.
And the integration of the care is there's all kinds of data to show that, integration of you guys, the primary care, the psychiatric provider and a therapist with communication has a huge impact on outcomes. But that's not the way most psychiatric practice or therapists practice. They don't communicate with each other. They're working at odds sometimes with each other. So that's another thing. Final thing about that I would say to add to that is don't continue, because a lot of you are comfortable with these SSRIs. And so if patients failed on 2 SSRIs, it's time to switch to. I've switched to venlafaxine, Effexor,
an SRI. I use that over Cymbalta because there's some data suggests that venlafaxine is a superior antidepressant, and it may well be, since the same mechanism of action, maybe it will be the Cymbalta could be as well, but we don't have that data. There's also difficulties we have with hepatotoxicity with Cymbalta in certain settings, and so it just makes me a little leery. So now in PMDD, it could be a great drug because often they also have a lot of those patients have a lot of somatization, so they're going to have, they're not uncommon with patients with fibromyalgia and the like, and so some pain issues that might be helpful there. So, but switching to an NSRI like Effexor and getting that dose up to 150 milligrams a day, if you fail an SSRI or two, is going to have a lot bigger yield than continuing to fail, because the widespread use of SSRIs allowed us to, I started practicing when we just had tricyclics, and trazodone came to market. I was in residency when Prozac hit, and what we gained ability to treat a lot wider. We had to treat only the very severe with tricyclics, with side effects and risks and the like. And so this allowed us to treat more patients more safely. I mean, the data on safety and, and deaths, ER visits with antidepressants and suicide risk with them, it went way down. So, but they never achieved the efficacy of the tricyclics, and that's probably because of the norepinephrine component. And so then you might see a patient, a really complex patient of mine who's on a tricyclics this day, or an MAOI, although I avoid them in pregnancy, MAOIs completely. So, but again, if you had a patient who's been on that, I've had the case of having to deal recently with someone who's on an MAOI who was pregnant, but that'd be the same principle being case. What would you do? You'd monitor really closely and the like. So, so that's that. I've got another take-home point for you guys. So, what we haven't mentioned is the second generation antipsychotics that we use all the time, right? Another point, quetiapine, Zyprexa, and all that. With primarily marketing, and lithium doesn't have anybody putting it on your shelves. They've really are overrepresented, and there's limitations for them and risk metabolic and long-term, but they can be safely used as well. I think that probably in terms of with lactation, I think the best data is on Zyprexa having the lowest, risperidone, and then quetiapine, and then some of the others it's worse. So, but that's consideration too as well.
With the, so you've got a patient, Rachel, or another one, say, and then she got to the point where she stopped her meds or was off meds and doing fine, gets pregnant again. I guess it would be my practice typically to start them on something late third trimester prior to delivery. Is there any data, or do you guys show any benefit to that as far as decreasing the incidence of recurrence?
If it's generally well tolerated, we have, again, mental health is limited data on almost everything, but the data we do have generally supports that if they tolerate the drug well, it's not a bad idea. I have a patient right now who that is our exact plan. She does not want to be on medication until about 36 weeks of gestation, but we've agreed, because her depression has been so severe in the past, that at about 36 weeks, we're going to start her up on escitalopram, because that's what she had taken previously and tolerated. And she's also a pilot, so with the FAA restrictions, that kind of limits what I can put her on as well. But that is one that's allowed.
Yeah, we see lots and lots of times that these are isolated events limited to one pregnancy too, and even psychosis. I mean, about 30% of postpartum psychosis is, even though we have all kinds of reasons to believe that heralds really probably potentially severe bipolar disorder, that about 25-30% they resolve and never an issue again in the person's life. So there's probably a lot of other factors that contribute. Those tend to be more, I've noticed, have accompanied by lots more of the obsessive compulsive symptoms, fear of contamination, and fears of harming baby. Sometimes those, again, really resolve with psychotherapy as opposed to any medication management. So there's just a subset of those that have a really good outcome, and it tends to be more of a acute psychotic disorder that's isolated, and generally it's in the setting of somebody, again, who's had a complex history, use, lots of distress going on in their interpersonal relationships and the like. So I once saw, just an anecdote, I just once saw a few years ago when hantavirus was all in the news, I saw a woman who postpartum, her husband went elk hunting and came home, and she suddenly, as he was walking in the door, thought that he might have hantavirus. And so she didn't let him in the house, and he slept in the barn for 8 months before I saw them.
Where he definitely got the virus.
Exactly. So, you know, I mean, but again, that woman got successfully treated for a period of time, never, and had subsequent children, never recurred. So but if you've had somebody who's had 2 episodes of major depressive illness, the chances of them untreated having a third are 80%. And the chances of them untreated of having the median episodes goes to about 8 or 10, then at that point you can't discriminate episodes because you get chronic debilitating symptoms, and they're almost untreatable, right? I mean, the struggle in medication, which I talked about with the neurosteroid that's going to be available, is that once you've been chronically ill, the chances of anything working for you diminish dramatically, and that's where the disability of depression is so high and common. So, but we really appreciate it. We love being here. I just talked to Patty that we want more time here, outpatient wise. You know, space is a limitation, so look around your offices. You know, you can squeeze us in. We've hired a lot of providers. We've got a lot of people that we'd love to because, you know, we see the need in West Omaha, and we see the need here. So appreciate working with you. I hope you guys all have my number in your phones. So if there's anything that comes up, I know at times there's some of my colleagues, psychiatric colleagues, have somewhat of a lack of enthusiasm about responding, coming over here. So if I'm around, I'm doing it. So just please reach out to me if you have any questions or complaints about Ben or all those things. I feel those daily. So all right. Well, thank you guys. Appreciate the chance to visit.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.